So good evening, everybody. My name is Lisa Marsters, and I'd like to welcome you to this evening's session, during which I'm going to cover some aspects of motivational interviewing from my own experiences to date, and also in my current role as the Senior Engagement Officer for Lincolnshire for the NHS Diabetes Prevention Programme, or the NDPP, as I will refer to it from now. I think as healthcare professionals, it's important for us to consider how we as individuals feel about the aspects of perhaps our own lifestyles that we'd like to change, and to explore the barriers in our own lives to making these changes, and more importantly, sustaining them in the long term, because that's really the key to it. 80% of my role involves providing that crucial link between the NDPP and primary care, both in terms of upskilling and updating clinical staff about the programme content, but also working with staff to support and guide them around having the most worthwhile interactions they can with their patients. So by being compassionate and non-judgmental, and by listening to the clues our patients are giving us during these consultations, we might get a flavour that they might be contemplating change. So I've worked on the NDPP since it began in 2016 in Lincolnshire. I was formerly one of the health and wellbeing coaches, and I've had the privilege of delivering this wonderful programme in and around Lincolnshire for 4.5 years. My own background is in public health nutrition and sports coaching, and I've also been involved in junior athlete development as a competitive swimming coach for over 25 years. With the latter in mind, the first thing I want to say to you is that we can't make somebody do something they don't want to do. But if they do, then by active listening and guidance and some support, we can be the facilitators of that change. Over the years, I've seen many highly talented swimmers who don't have what is required mentally for them to develop their skill, because they perceive the amount of effort required by them to do it is just too much, or it's not a priority to them. Swimming in particular is an endurance sport, and the level of commitment and the hours of training required in order for that junior athlete to continue to progress is not for the faint-hearted, and so they give up. At the end of the day, the effort is required to change by the individual, so they have to really want to do it. A lot of us become more resistant to change the older we get. We find it unsettling, and we get comfort from doing what we've always done. And most of us would probably say that we all know what we should and shouldn't be doing. So why aren't we doing it? What is it about our mindset that puts us in a perpetual cycle of procrastination and self-recrimination? It could be that we're eating too much, or not eating well enough, drinking too much alcohol, not doing enough exercise, and not making ourselves and our own health and well-being a priority. Many of us are part of the sandwich generation. We're the generation who might still have responsibility for children living at home, but also that of aging parents who may be struggling with long-term and progressive conditions, things like dementia. We've got stress coming at us from all directions, leaving us time poor and perpetually exhausted. But as we begin to ease out of COVID, I'm sure you'll agree that never more so than now has our own health and well-being been more important to us. And we all have a duty of care to play to both ourselves and our patients in this. So, for example, we know that 1/3 of those who died of COVID also had type 2 diabetes. So why, when we do decide to do something, do we so often set ourselves up to fail by tackling too much in one go and subsequently failing, or wanting instant results from our endeavours, which means we can just continue to procrastinate and do nothing. We do live in a very blame-centred culture, particularly around the subject of weight management, and we're subject to lots of conflicting advice. And this is something which is frequently stated by our patients as a barrier to change. They say, I'm always hearing conflicting advice, and so I don't know what to believe. Alcohol's a good example of this. One day it's beneficial to health, and another day it's bad. It's bad for us. Advice does change. It changes as a result of us learning more and more about a subject as time goes by. Smoking being the perfect example. There was a point in time, a long time ago, when smoking was actively encouraged as a health promoting activity, but luckily things change. Screening and prevention are the gifts of our time, and prevention must play a key role in reducing the future burden of healthcare provision on all of primary care. And if we understand our patients' important values in life, such as wanting to be independent for as long as possible and not be a burden on their families, most of our patients would perhaps say that. So the goals we can encourage them to set for themselves can align with these core values. But how do we go about this? Think of lifestyle change as a huge pile of ironing. The bigger the pile gets, the more daunting it becomes, and the less inclined we feel about tackling it. In desperation and because of occasional necessity, we may have to address the occasional crisis or health scare and iron a shirt or a pair of trousers. Or again, using health as an analogy, we might want to lose a few pounds for a wedding, an important event, or an operation. But that pile of ironing is still there, and every time we look back at this ever-increasing pile, we're looking at it as a whole. And the more we look at a problem as a whole, the less equipped we feel to deal with it. So that might lead us to feel less and less in control of other aspects of our lives and outcomes, and often leads to a generalised negative attitude, giving up generally on a willingness to change anything, having, say, attempted numerous diets over the years, which work at the time, but are never sustainable. The incentive to change is different in every one of us, but often a health scare in the form of an unexpected blood result may present us with the opportunity to have these difficult conversations around some more manageable lifestyle change. What if you looked at that massive pile of ironing and decided, with help and support, to come up with a structured plan to tackle it? Small changes that would add up over time. What could this plan look like? How could you divide up the pile? Perhaps by colours, by individual items, say. And what if then you set yourself some realistic targets of ironing, say 3 things a day? And compromise on the things which genuinely don't need ironing. These would be aspects of our lifestyle that genuinely don't deserve the focus we currently give them. They really don't matter. If we as healthcare professionals have had to work hard for our own achievements and have experienced failure along the way, then we will probably have more empathy when it comes to facilitating a plan of realistic goal setting with our patients, who may also be struggling. Thinking again of a sporting analogy, elite sports athletes all have one thing in common: they never give up. Take Andy Murray as an example. I'm sure we all know who Andy Murray is. He's triumphed over adversity many times. He's had lots of operations which weren't successful. He's had to miss crucial training opportunities and tournaments along the way. But he never gives up, and anyone who achieves anything worthwhile never has it easy, but they all have this one thing in common, in that they never give up striving for their goals. No one who achieves anything worthwhile does it without failing, sometimes spectacularly along the way. We're all naturally hard on ourselves, and we rarely give ourselves credit for the things that we have achieved. I'd like, if I may now, just to address some of the common barriers that come up when inviting patients to participate in the NDPP, and how we as practitioners can have a better understanding of the programme in order to motivate our patients to want to participate, giving them the opportunity to change their lives, take control, and avoid becoming diabetic. Lack of time is often used as a barrier to change. But in reality, we'll always find the time to do the things we want to do and the things that are really important to us. What is the saying? If you want something doing, ask a busy person. In terms of the NDPP, patients are often put off by the length of the programme, which is 9 months. On face value, this seems like a massive undertaking and claim on their time for something which, to begin with, they know very little about. This 9 months actually equates to 25 hours, which is a day of their lives, spread out over a 9-month period of ongoing support. The commitment is an hour session per fortnight for 7 sessions, and then an hour session once a month for 6 sessions. Once it's been explained, this sounds far less daunting. And it's why we need to consider how our patients are going to interpret the information we're providing them with. How can we put things into context? Secondly, it's not specifically a weight loss programme. It's a blood glucose management programme. We need to stop fixating on weight and start concentrating on health. Weight loss may well be a welcome coincidental side effect of this health improvement. Most of us have families, and we want to be around to enjoy watching our families grow and develop. If we have children, we desperately want to be around to see them grow up and do all the things that make them the wonderful adults they become, and possibly then have children of their own. And then when we become grandparents, we move the goalposts, because if we're lucky enough to have grandchildren, we want to see them grow up as well and be an active part of their lives. If this is important to us, we'll need to be as fit and healthy as possible, and we might be more inclined to make some small changes to our current lifestyle. Losing a little bit of weight might improve our mobility, meaning we can be active participants with our families. We all know when we're overweight, and we don't need anyone to point out the obvious. Many of our patients, and indeed we ourselves, are extremely self-conscious and prickly about our own weight. And when coming along to a practice appointment, patients might already be apprehensive and defensive about being overweight and wary of being fat shamed and told that they need to lose weight. If we're educated about how various aspects of our current lifestyle might be adversely affecting our overall health and our possible longevity, then we've got the choice to choose to change as a result of this new understanding and how it might benefit our future health. It's worth mentioning here the link between menopause and lifestyle change. Women transitioning through menopause, which is a long-term hormone deficiency, are much more likely to struggle with their weight. As a result of no longer ovulating regularly, we need around 200 to 300 calories less than we did, which equates to about £1 a month weight gain. And that could be the extra snack, the glass of wine, the 2 or 3 biscuits that we might have got away with as part of our daily intake. And it often results in this unexpected, consistent weight gain without us doing anything different. And not many women are aware of this. Also, this extra weight is more likely to sit around the abdomen because our fat stores also store estrogen. And without it, our fat cells hold on to additional fat and make it a lot more difficult to get rid of. This increased belly fat also puts us at increased risk of type 2 diabetes. Did you know as well that during this transition, we are more likely to crave carbohydrates and alcohol? Women at this stage of their lives, which is really anything from around 45 onwards, often complain that they're not sleeping well. They may have debilitating muscle and joint aches and pains, and they may have been prescribed antidepressants, as opposed to having their menopausal symptoms treated with replacement hormones, as stated in NICE guidelines. Women's metabolisms slow down, making our fibre and fluid intake far more significant, which might also explain the regular bloating that many women at this stage of their lives complain about. Because of this, our own lifestyle choices become far more critical at this time, and our bodies may react more sensitively to poor choices that we make. But this isn't our fault. If we haven't slept well, perhaps we're on antidepressants, are we going to be inclined to exercise regularly? Apologies to any gentlemen listening to this evening, as this is very biased towards women. But every woman, every man knows a menopausal woman, and we all, men and women, need to be empowered to know that we have choices and are able to support others around us to make these choices. The NDPP is a bespoke programme for patients at significant increased risk of becoming diabetic, which is in the range of 42 to 47 millimoles per litre. 80% of type 2 diabetes is lifestyle related, which means we might, by participating in a programme of education and understanding what type 2 diabetes is and what aspects of our own lifestyles may be contributing to this risk, be inclined to make some small changes, which in turn would push this risk further away. If we're to understand willingness to change from our patient's point of view, we might want to put ourselves in their shoes by considering these questions for our own lives and perhaps using them with our own patients. You might want to write these down if you're interested. So my questions would be, what are 5 pros and 5 cons about your own current lifestyle? What aspect of your current lifestyle do you want to, number 1, start, number 2, stop, and number 3, continue with? Where do you see yourself in 3 months' time? And how are you going to achieve it? If you'd like any more information, you're welcome to contact me. I'm going to put a slide up at the end. But yeah, that's back to Ruth. Thank you.
Thank you very much, Lisa. That was some really useful insights there. Does anyone have any questions for Lisa? I think, Lisa, if you are happy to share your contact information, I know often queries occur to people at a later time. So lovely. So yeah, they've got Lisa's email and phone number as well. So I'm sure, Lisa, correct me if I'm wrong, I'm sure you'd be happy if people did get in touch to ask more.
Yeah, absolutely.
Lovely. Great. If there's no more questions, I'll say thank you very much. Oh, got a question from Jenny.
Really sorry. Can people self-refer, or do they have to be referred by a GP to the service?
That's a good question. The gold standard referral is the opportunistic referral, because if you're sitting in front of your GP and your GP says you should go on this program, you'll get a lot of benefit from it, that's more likely to be a successful referral. But patients can self-refer. They can self-refer using the Know Your Risk tool on the Diabetes UK website. If they score, I think it's 16 and above on the questions that they're asked, they will be automatically given the link and they can refer. But also, if you know your HbA1c result and it's within 2 years of age, that changes on the 1st of April. We're going back to 12 months. So if your HbA1c is within that 42 to 47 millimoles per litre, and you know your NHS number, you can self-refer that way. Yeah, if you go onto the website. If you want to contact me, I can send you the link.
Thank you.
Pleasure.
Lovely. Any further questions? I have a question actually. Lisa, do you have any case studies of people who've been through the programme that could be used as resources?
Yeah, absolutely. Yeah. And I have actually sent those out to primary care in the past. We've got a lovely gentleman who was a patient at Market Deep in practice, and he was on one of the programmes that I delivered, and he's actually done a video case study for us. So yeah, that's available too.
Perfect. If anyone would like that, do feel free to get in touch with Lisa. I've got a question from Paul. Is the programme face-to-face or online?
Yeah, that's another really good question. So obviously during COVID, we've been delivering remotely via Teams. We also have an audio-only version available. So the patient, the only requirement of the patient is they've got a telephone. We are going to start phased face-to-face return as of the 1st of April. And we will be entirely face-to-face by the beginning of July. So it's going to be a 3-month phased-in approach. And we also have a digital app that you can use as well. Yeah.
Perfect. Any further questions? Okay, well, I'd just like to say a big thank you to Lisa for presenting tonight. Yeah, I found that really useful for myself, just listening in. And thank you all for coming along. Yeah, do feel free to contact Lisa with any further questions. And yeah, so thank you and good night.
Thank you for your time. Enjoy your evening, everybody.